My name's Helen Daniels. I've been working as a researcher for Swansea Medical School since 2013. I was a qualitative researcher initially, but I switched to a data scientist role in 2019 and started working on Ashley Akbari's team. So this last year, we've been working on a project with the Health and Care Research Wales Evidence Centre on persistent pain. So I'm going to take you through some of the key findings from this work. We looked at how common it is, who it affects most, and how people living with persistent pain are using healthcare services. So first of all then, what do we mean by persistent pain? So this refers to pain that lasts for more than 3 months. Could be anything from back pain to headaches or nerve pain. So unlike short-term pain from an injury, persistent pain doesn't just go away. It can deeply affect people's lives physically, emotionally, and socially. We know that persistent pain is a public health concern, and it's thought that between 35 and 50% of the population of Wales are affected. That's a pretty high number, but despite how common it is, services and support vary a lot. There are multiple demographic and socioeconomic factors associated with the condition, such as deprivation, unemployment, aging, and smoking. And we also know that there are significant gaps in the research that need addressing to improve prevention and treatment. So in 2023, the Welsh Government published their guidance, Living with Persistent Pain, and they made persistent pain a national priority. So given the extent of the issue, and not least due to the current financial climate, the Welsh Government is keen to address the evidence gap regarding the management of individuals experiencing persistent pain. So linking into that research need then, our work on persistent pain is a result of a request by NHS practice leads for the HCRW Evidence Centre to help provide this evidence to inform decision-making around future services, capacity planning, and for implementing health policies. All of these then will expand on the Welsh Government's 2023 guidance. Okay, so what were our objectives? So what we wanted to do was identify people in Wales who are living with persistent pain from electronic health records, find out how many people are living with persistent pain in Wales. We wanted to compare the characteristics of those who are not living with persistent pain and between those who had been referred to specialist pain services and those who had not. And then finally, then we wanted to describe and compare the health resource utilisation patterns for these individuals. So how we did it. So this was a retrospective cohort study using anonymised, routinely collected data from across Wales stored in the SAIL databank. We worked with our stakeholders to come up with 3 ways to define people with persistent pain. There isn't a medical register of people who have been diagnosed with persistent pain, so using these 3 ways meant that we included as many people as possible. So these 3 ways were if they had a diagnosis of pain, so persistent pain read codes and ICD-10 codes in GP and hospital data respectively. Secondly, they've been referred to a special pain clinic. We found these referrals in the outpatient data sets in SAIL. And thirdly, then, if they'd been prescribed gabapentinoids or opioids for 3 months or more. And people could be in 1, 2, or all 3 of these groups, depending which applied to them. We also created a comparison group of people who didn't fall into any of these groups. All study participants were residents in Wales and were registered with a SAIL providing GP. We measured 2 types of outcomes, the monthly counts of people with persistent pain and the monthly counts of healthcare utilisation. We used those then to create rates of healthcare utilisation. What we found, the study period ran between the 1st of January 2010 to the 31st of December 2023, and we included just under 4 million people into our study overall. 15% of the population met at least one of our criteria for persistent pain. That's about 1 in 7 people. This Venn diagram shows you how the 3 definitions of persistent pain overlap. As you can see here, the biggest group was the pain diagnostic codes, then those who were taking pain medication, and then those who were referred to pain services. So these numbers represent the first instance of one of these codes for an individual during the study period. So this graph then shows you the rate per 100,000 people of people per year identified living with persistent pain. And it shows that the numbers are going down, and it was doing so with statistical significance. This is actually counter to what we and our stakeholders expected, and I'll address that at the end of this presentation. So the red line going at the top represents everyone we identified as living with persistent pain at some point in the study. What we also did then is we separated all those who were identified as being in persistent pain, who had not been referred to specialist pain services. Those are shown in yellow. The lower three colours then are the three separate groups of people dependent on how they were identified. So you have the green line is the pain diagnostic codes, the pink line are those who were referred, those who had prescription for pain medication, and the blue line is for the people who were referred to pain services. So when we looked at the demographics, we found that persistent pain is more common in older adults, especially those aged 61 to 70, more common in women, and no surprise, people living in more deprived areas. It's also linked to poor overall health, with people in persistent pain more likely to have multiple long-term conditions and be classed as frail. Looking at healthcare utilisation then, we measured healthcare use in 5 different ways. We looked at GP events, hospital admissions, emergency hospital admissions, emergency department attendances, and outpatient attendances. We compared the pain cohort to the general population, or our comparator group. And after adjusting for age, sex, deprivation level, seasonality, and changes in the size of the population at risk, we found that for people with persistent pain, there was a 63% increased risk of a GP event. And that shows just the huge impact on the NHS. And there are also higher emergency hospital admissions, higher emergency department visits, and higher outpatient appointments in this group as well. There was a decreased risk of hospital attendances. These time series plots show you the comparison of rates per 1,000 people of healthcare utilisation measures. People with persistent pain are in black, and you can clearly see the effect of COVID-19 in these graphs as well. So, who gets referred to pain services? So only around 12% of people with persistent pain were referred to specialist clinics. So these people were slightly younger, they were less frail, and more likely to be women again. They also saw their GPs more often than those who were not referred to specialist pain services. So this then could mean two things. It could mean that this group had the most severe pain and were in more need of services, or it could suggest that they were more able or motivated to access care, while others, especially older people, might be missing out. Coming back to this then, why is the trend in people with persistent pain going down? So we thought about this for a while, consulted with our stakeholders, and we came up with some reasons. There could be changes in how doctors record diagnoses that we weren't picking up in the data. Also, there could be less reliance on long-term opioid prescriptions. This would mean that our prescription group was diminished. This links to changes in clinical guidance, where around COVID time, where doctors are being encouraged to be more frugal in prescribing these drugs because of addictive qualities mostly. Also, people could not be visiting their GP due to barriers like transport, cost, digital exclusion, especially for older people, which would mean that we are not picking them up in our electronic health records. It's also possible that people are managing their pain in other ways, like exercise or mindfulness, meditation, that sort of thing. In conclusion, then, people in persistent pain are older, more deprived, more frail, have more comorbid conditions, and are using healthcare services more than the general population. We identified that around 15% of the population live with persistent pain at some point in their lives. And this is lower than some of the literature reports. Often these reports have identified people by self-report. So either there's a difference between the number of people being coded as having persistent pain compared to those who are actually living with it, or it could be that not all those who are living with persistent pain are accessing medical care at all. So to build a clearer picture, we need to combine this data with people's own experiences, look at how non-drug treatments are being used, and understand the barriers that people face, especially in older age and in more deprived areas. In this way, then, the Welsh Government can make sure services are reaching everyone who needs them. The full report on this is available on the HCRW Evidence Centre website. I'm very happy to answer questions, or you're also welcome to email me as well with anything you'd like to know about the work. Thanks very much.